Hello everyone. Our topic today is about imaging of pheochromocytoma and paraganglioma. We will start our video with an introduction in which we will discuss the definition of pheochromocytoma and paraganglioma. Then we will discuss the anatomical imaging modalities including CT scan and MRI. And finally, we will talk about nuclear imaging modalities including MIBG, gallium dotatate scan, and other functional imaging modalities. So, what's pheochromocytoma? Pheochromocytomas are catecholamine secreting tumors that arise from chromaffin cells of the adrenal medulla. And as we can see in the image here, they are only located in the adrenal gland. On the other hand, paragangliomas are rare neuroendocrine tumors that arise from the extraadrenal autonomic paraganglia. They are subdivided into parasympathetic and sympathetic paragangliomas. For parasympathetic paragangliomas, they are usually non-functional, and they are located along the glossopharyngeal and vagal nerves in the neck and at the base of the skull. And as we can see in panel B, the most common site for parasympathetic paragangliomas is the carotid body paraganglioma. Other examples include glomus tympanicum, glomus jugulare, glomus vagali, and the aorticopulmonary paragangliomas. And when we look at panel A, we can see that sympathetic paragangliomas arise from the paravertebral sympathetic chain anywhere in the thorax, abdomen, and pelvis. The most common site is paraganglioma of the organ of Zucker-Kandel. Other examples include posterior mediastinal paraganglioma, retroperitoneal paraganglioma, and urinary bladder paraganglioma. Sympathetic paragangliomas usually secrete catecholamines, and clinically, they are indistinguishable from pheochromocytoma. This is a simplified algorithm on how to approach a patient with a suspected catecholamine secreting tumor. The clinical importance of catecholamine secreting tumors is based on how to suspect, confirm, localize, and treat accordingly. Suspect, confirm, localize, and treat accordingly. And the most important step for diagnosis of catecholamine secreting tumors is first to recognize the possibility of the tumor. Catecholamine secreting tumors should be suspected in patients who are presenting with the classic triad of headache, sweating, and tachycardia, whether or not associated with hypertension. Also in patients with a familial syndrome that predisposes to catecholamine secreting tumor, like multiple endocrine neoplasia type 2, von Hippel-Lindau, and neurofibromatosis type 1. Also in patients with a family history of pheochromocytoma or paraganglioma. And finally, in patients with an incidental adrenal or extra-adrenal mass. When there is a clinical suspicion for catecholamine secreting tumor, we should proceed to the second step, which is confirmation of the diagnosis. To confirm the diagnosis, we perform biochemical testing, which includes measurement of plasma-free metanephrines or urinary fractionated metanephrines. This is according to the Endocrine Society guidelines. The results are diagnostic when it's twofold above the upper limit of normal. After biochemical confirmation of the diagnosis comes the role of radiologic imaging, which is our topic today. Imaging can provide information about tumor localization, and the imaging modalities used include CT scan, MRI, and radioisotope imaging using different radiopharmaceutical agents. Concerning the genetic testing, the field of genetic testing is rapidly evolving, and at many clinical laboratories, sequential genetic testing, which is suggested by the Endocrine Society guidelines, is no longer done, as it's being replaced by next-generation sequencing technology, which is less expensive, and we could do the tests for all clinically available mutations as one package. So let's say we have now done our screening tests and the levels came back diagnostically elevated. The next step is to localize the primary tumor. What I usually recommend is that CT scan and MRI is your best first option for localizing the primary tumor. And I would like to begin with CT scan. At first, we have to understand what does the Hounsfield unit mean. Hounsfield unit is a relative quantitative measurement of radiodensity of tissues. The physical density of any tissue is proportional to the attenuation or absorption of the X-ray beam. And when we look at the Hounsfield scale, we will figure out that cortical bone absorbs most of the X-ray beam and shows the highest attenuation value of more than 1000 Hounsfield units. In contrast to air, which absorbs almost nothing of the X-ray beam and shows the lowest attenuation value of less than 1000 Hounsfield units. Water was arbitrarily given the value of 0, with fat density being less than water and soft tissue being more than water. That's why adrenal adenomas, which are usually lipid-rich, have Hounsfield unit of less than 10. However, pheochromocytomas, paragangliomas, lipid-poor adenomas, and adrenocortical carcinomas, which are all lipid-poor, have a Hounsfield unit of more than 10. Again, I would like to emphasize that a CT scan is the best first option for localization of the primary tumors. And as we can see here, this is a computed tomography of a 32-year-old Japanese male. Panel A shows a non-contrast study, and as you all can see, there is a 6 cm left adrenal tumor with calcification at the margins, as indicated by the red arrow. And panel B shows the CT of the same patient after administration of the contrast, showing the heterogeneous enhancement of the tumor. So, the CT imaging characteristics of pheochromocytoma are based on some facts, including that pheochromocytoma is a soft tissue tumor that does not contain an excessive amount of fat like benign adrenal adenoma. It also contains many areas of hemorrhages, necrosis, and cystic degeneration. And it's a highly vascular tumor. These all lead to the characteristics that we see in this table. There is increased attenuation on non-enhanced CT scan, and in most cases, pheochromocytoma has an attenuation value of more than 20 Hounsfield units. And this is, as we mentioned, because pheochromocytoma is a soft tissue mass that does not contain an excessive amount of fat like a benign adrenal adenoma. The second characteristic is that pheochromocytoma usually appears heterogeneous because of the areas of necrosis and cystic degeneration, which appear more hypodense than the surrounding tumor tissue as seen in panel B. Also, pheochromocytoma typically enhances avidly because of the increased vascularity as seen in panel B also. The last characteristic is the delayed contrast washout, with the absolute contrast washout of less than 60% and the relative contrast washout of less than 40%, 10 to 15 minutes after administration of the contrast. And I will discuss this in the next slide. And to understand how the radiologist calculates the contrast washout, at first, he measures the Hounsfield value before injection of the contrast, and this is called the HU native. Then, he measures the Hounsfield value 1 minute after the injection of the contrast, and this is called the HU maximum. And finally, he measures the Hounsfield value 10 to 15 minutes after injection of the contrast, and this is called Hounsfield 10 over 15 minutes. Then, he uses the equations below to calculate the relative and the absolute contrast enhancement washout values. And as we have learned from the previous slide, pheochromocytoma and paraganglioma have a delayed contrast washout with an absolute washout of less than 60% and a relative washout of less than 40%, 10 to 15 minutes after administration of the intravenous contrast. However, adrenal adenomas tend to have a rapid contrast washout. And when we look at panel A, it's an axial contrast enhanced CT portal venous phase of the upper abdomen showing a pheochromocytoma in the right adrenal gland. And we can see that it shows avid enhancement due to the capillary-rich framework of the tumor. And panel B represents the delayed phase. The second imaging modality is MRI. MRI is not the first choice imaging tool in case of pheochromocytoma because its spatial resolution is inferior to that of the CT scan. It's indicated in certain situations in patients with pheochromocytoma paraganglioma, including patients with metastatic disease, patients with head and neck paragangliomas, and whenever there is a contraindication to CT scanning, like the presence of an allergy to CT contrast agents, and also in children and pregnant women. Pheochromocytomas have variable intensity on T1 weighted images. They are hypointense in comparison to the liver in most cases. As seen in panel A, there is a mass in the right adrenal gland, which has a lower signal intensity than that of the liver, indicated by the red arrow. They sometimes show a bright signal in T2 weighted images, known as a light bulb sign, in around 1/3 of cases, as seen in panel B. Pheochromocytomas have no loss of signal intensity on in and out of phase imaging due to low lipid content, as seen in the top image, which represents the in-phase image, and the bottom image, which represents the out-of-phase image. Both show an adrenal mass with almost the same signal intensity. In the out-of-phase image, we cancel out the fat signal intensity, so benign adrenal adenomas, which are rich in fat content, tend to have a drop in signal intensity in the out-of-phase image. Before I'll explain different nuclear imaging modalities, I'll go through the targets for nuclear imaging of chromaffin cells. Chromaffin cells, as we see here in the image, express different transporters on their surface. These transporters may act as receptors or channels for different molecules. Labeling these molecules with radioactive substances has many diagnostic and therapeutic implications. For example, labeling MIBG with radioactive iodine is beneficial. MIBG is structurally similar to norepinephrine and can access the chromaffin cell through the norepinephrine transporter. And likewise, we can benefit from the presence of somatostatin receptor to perform a gallium dotatate PET scan, and from L-amino acid transporters to perform F-DOPA PET scan, and from glucose transporters to perform FDG PET scan. So, what are the clinical indications for nuclear imaging? The first indication is to confirm the diagnosis of pheochromocytoma paraganglioma. In most cases, nuclear imaging is indicated at the initial presentation of pheochromocytoma paraganglioma, with only one exception, in which the primary tumor is located in the adrenal gland associated with elevated epinephrine levels. Sympathetic nerves are incapable of synthesizing epinephrine because they are PNMT deficient, and epinephrine is only produced in the adrenal glands. That's why there is no risk of metastasis or any other primaries elsewhere in the body in patients presenting with adrenal pheochromocytoma and epinephrine phenotype. Anatomical imaging is enough in this case. Another indication of nuclear imaging is for staging purposes, whenever the risk of metastasis is high, such as in patients with SDHB mutation, in patients presenting with large-sized primary tumors more than 5 centimeters, in patients with extra-adrenal location, and finally in patients with norepinephrine or dopamine phenotypes. Another indication for nuclear imaging is for follow-up purposes. We can either use whole body anatomical imaging or functional imaging. However, functional imaging is more specific and can locate the tumors in unusual sites. So, it's more accurate in determining further management plans. Functional imaging is also beneficial when we are planning to treat a patient with radioisotopes. This is called theranostics, which is rapidly evolving these days, especially in managing neuroendocrine tumors and pheochromocytoma. I will continue the presentation by explaining the only functional imaging modalities related to theranostics, which are MIBG and dotatate PET scan. So, what's MIBG? MIBG is a substance which has a similar structure to norepinephrine. It's radiolabeled either by 123 iodine or 131 iodine. 123 iodine emits gamma rays, which could be detected by gamma cameras and is used for diagnostic purposes. However, 131 iodine emits beta particles as well, which can be used for therapeutic purposes to ablate tumor cells. The uptake of MIBG into the chromaffin cells takes place through norepinephrine transporters. Then, vesicular monoamine transporters facilitates its transport from the cytoplasm into the storage vesicles. There is a long list of medications that interfere with MIBG imaging, including opioids, tricyclic antidepressants, sympathomimetics, antipsychotics, and some antihypertensive medications. These drugs should be stopped if possible 7 to 14 days before the scan. The sensitivity of MIBG scan is estimated to be from 52 to 75%. The cause behind that is the lack of expression of norepinephrine or vesicular monoamine transporters in the dedifferentiated tumor cells. Pheochromocytoma and paraganglioma patients with decreased sensitivity to MIBG scan include patients with SDHB mutation, those with metastatic disease, and patients with head and neck paragangliomas. For these patients, MIBG is still beneficial to determine who could benefit from 131 iodine therapy. And this image to the right is an example of MIBG scan. Panel A shows a whole body planar image, and panel B shows, from left to right, coronal and axial attenuation corrected SPECT images. And for panel C, from left to right as well, an axial non-enhanced CT scan and SPECT fused to CT for better localization and resolution. These images represent the actual MIBG scan of a 40-year-old male patient with elevated circulating catecholamines. As we can see, there is a right adrenal mass around 4 cm in diameter with intense MIBG uptake, much greater than the hepatic uptake, which is consistent with pheochromocytoma. The second functional imaging modality is 68 gallium dotatate PET scan. And to understand how it all works, we have to go back to the key and lock principle. The lock in our case is somatostatin receptors that are present on the surface of chromaffin cells. In pheochromocytoma and paraganglioma, the most prevalent type is somatostatin receptor type 2. The key is composed of 3 parts: the ligand, the linker, and the chelator. The ligand, the linker, and the chelator. The chelator is the part that will carry the radioisotope. And we use different types of radioisotope. This is another application of the concept of theranostics. For diagnostic purposes, we use gallium-68. However, for therapeutic purposes, we use Y90 or lutetium-177 as a part of PRRT therapy. The linker is the part which connects the chelator to the ligand, and it's called DOTA, so we call it dotatate. In Octreoscan, they use a different linker called DEPTA. The ligand is the last part of the key that will bind to the lock, which is the somatostatin receptors, as we mentioned previously. So, the ligand will be one of the somatostatin analogs, octreotide or octreotate, which are shown in the figure and the table to the right. We have different DOTA-coupled somatostatin agonists, namely dotatate, dotaTOC, and dotaNOC, which are different among themselves in their affinity to the somatostatin receptor. Back to the key and the lock. After the ligand binds to the receptor, the ligand-receptor complex becomes internalized and retained inside the chromaffin cells. And this has different diagnostic and therapeutic implications. When we talk about diagnostic accuracy, gallium dotatate PET scan is the best functional imaging modality. It has the highest sensitivity and specificity among them all, especially in patients who belong to the cluster 1A mutation subtype, associated with any type of mutation in the SDH gene. It's also the imaging modality of choice in patients with metastatic disease and in patients with head and neck paragangliomas. These images to the right prove the superiority of gallium dotatate to FDG PET scan in cases with familial and metastatic disease. They belong to a 60-year-old woman with a familial pheochromocytoma paraganglioma syndrome, status post-right adrenalectomy, who presented with a recurrent increase in plasma metanephrine level 5 years ago. Panel A represents the MIBG scan done during that time, 5 years ago. From the left to the right shows a whole body MIBG scan, then an attenuation-corrected SPECT. The third image represents an axial CT image, and finally to the right is the fused SPECT CT image, which was done to assess for the recurrent increase in plasma metanephrine levels discovered during post-operative follow-up. That MIBG study showed increased uptake in multiple osseous lesions indicated by the white arrows. The patient had been subsequently treated with iodine-131 MIBG therapy at that time. Recently, the patient presented again with elevated tumor markers. An FDG PET scan was arranged, which is shown in panel C. It showed minimal to no uptake in the whole body. To assess for any occult recurrent disease, another PET scan was performed 1 week later, but this time using gallium-68 dotatate, which is shown in panel B, and demonstrated widespread somatostatin receptor positive bone metastatic disease with marked tracer uptake, which is indicated by the arrows. This denotes that gallium dotatate PET scan is superior to other functional imaging modalities in all cases of pheochromocytoma and paraganglioma, except in patients with sporadic or inherited pheochromocytomas who belong to cluster 1B and cluster 2 mutation subtypes. In these cases, F-DOPA is the best. And this table is from the European Association of Nuclear Medicine Practice Guidelines 2019, which shows the proposed clinical algorithm for nuclear imaging in patients with pheochromocytoma and paraganglioma. They recommend the use of gallium dotatate PET scan as a first choice in cases with extra-adrenal sympathetic or parasympathetic paragangliomas, and it comes as a second choice in patients with pheochromocytoma, either sporadic or inherited, except for those patients with SDHX mutations. For those patients with sporadic or inherited pheochromocytomas, F-DOPA PET scan is always the best option. FDG PET is always the third choice if neither gallium dotatate nor F-DOPA PET scan is available. These are my references. Thank you so much, and I hope you enjoyed it.